Dr. Nelson Trujillo is a cardiologist, and heart disease is both anatomically and metaphorically central to our existence and challenge these days. And he has worked with Larry, and I asked him, as a biomedical engineer and a physician and a cardiologist, how are your ideas today, having worked with Larry, different than what we would hear if a biochemical engineer, physician, cardiologist who hadn't worked with Larry were standing up here? And he said, dude, you'd steal my thunder if I told you that. So ladies and gentlemen, Dr. Nelson Trujillo.
Thank you. Well, the first thing I have to say is that having worked with Larry, and I'm sure all of you in this room are concerned, he does have a heart. So. I can't tell you how privileged it is for me to be here today speaking before you and in such incredible company. Having attended last year and being here this year, it engenders so much conversation, so many ideas, and it really brings joy into participating in both the sciences and the arts and all the different aspects of a full life. And so thank you all for being here, and thank you, Larry, for inviting me. Anybody who goes to Florence should check out the Speculum Museum. In Florence in the 1600s, you couldn't do dissections, and that museum has one of the most incredible wax anatomic figure collection I've ever seen in the world. And your dissections are exquisite. I put them up against these wax figures from the 1600s. So the Speculum Museum on the other side of the Arno, make sure you check it out. So my topic today is the contemporary prevention of major cardiovascular events and an existential crisis. And having been in practice now for about 30 years, I've only had one job here in Boulder. The first existential crisis that I face just about every day is, Doc, am I gonna die? The answer is yes. With 100% certainty, there's only two things you'll hear from me today that are 100% certain. The answer is yes, hopefully natural causes. He died of natural causes. Well, you pushed him off a roof. Well, gravity is natural. We're all very concerned about this death process and how we're going to die. And another existential crisis is, well, Doc, when? And I wish I had a good answer for that for all of us in the room. But we're concerned about that on a day-to-day basis. And in today's world, we're not only concerned about life expectancy, but health span. And of course, we all want to have a really great life and have a really bad day. But that's not how often it occurs. Sometimes we start to develop disease processes, chronic diseases, arthritis, heart disease that limit us. In the United States, the male life expectancy is 76 years of age. We start to deteriorate on average at around 67. And in women, life expectancy is about 81 years in today's world, and their health begins to deteriorate around 70. Cardiovascular disease is ever present and a major contributor to both our health span and our lifespan. And no good cardiologist would start a talk without the staggering statistics. 20.5 million deaths worldwide last year attributable to atherosclerotic cardiovascular disease. It's the leading cause of death in the United States, over 700,000 deaths last year. It's about one death every 30 seconds. So as we sit here today, you can imagine. And probably all of us in the room have been touched by cardiovascular disease in some way. A loved one, ourselves, a friend, close friend. 3 weeks ago, one of my closest friends in my wedding, sitting at his computer, doing his rounds at the hospital, just passed away suddenly from cardiovascular disease. So it spares no one, and it touches us all. Nobody writes poetry about the elbow. It's all about our heart, and it touches all of our souls. The costs are staggering. Estimates are $252 billion in healthcare services and lost productivity every year. I don't need to impress upon you further that this is a ubiquitous process. It touches all of us and deserves our attention. The problem is it's so common as to be almost invisible, and nobody really considers it until someday in their life where a loved one is touched or a diagnosis is made. We often ignore it and don't even think about it for quite some time. Treatment for heart disease is amazing. My career has spanned now 32 years. When I started in cardiology, we were the gentlemanly profession. We all dressed well. We held people's hands while they suffered from a heart attack or a stroke. We pushed morphine so that they remained comfortable, and we lost a lot of patients. People loved us, though. Cardiologists were always highly esteemed for their bedside manner, sitting there with patients as they died. And shortly after I started, it became a surgical specialty. Now we rush in the middle of the night, we put devices in, we do angioplasties, we send people to surgery. But this process has been really remarkable in the last 30 years. Mortality associated with acute myocardial infarction or a heart attack in the 1950s was about 30% if you made it to the hospital. 50% of people died before they even reached medical care. In the 1960s, we developed the ability to defibrillate people, to deliver a shock. It's why we call 911 when we're having a heart attack. It's not to get to the hospital faster, it's to get a defibrillator to us, because people die from cardiovascular disease from the electrical disturbance, not the blockage per se. In the 1980s, with work by Marcus DeWood up in Seattle, who was a cardiac surgeon, he did an emergency autopsy. When people were having a heart attack in the emergency department, he took them right to the operating room, opened up their chest, and showed for the first time that heart attacks were caused by blood clots in the heart. He did emergency bypass surgery, and that revolutionized care for cardiac emergencies. We developed blood thinners that were quite aggressive at dissolving blood clots, streptokinase, TPA by Amgen, such that by the 2000s, mortality from a heart attack fell from 30% down to around 7%. It fell an additional 2% with the ability to do angioplasty in the middle of the night, which is our current standard of care. If you show up with chest pain and a heart attack, you'll be whisked off to the cath lab, and one of us, interventional cardiologists, will open that blockage with a balloon or a stent. Now, this process, at this point in time, has gotten quite dramatic. There are lots of risk factors and ways to predict these events earlier. Global risk factors, and the biggest global risk factor we face is high blood pressure or hypertension. High cholesterol, a huge part of why people develop atherosclerotic cardiovascular disease. The rising rates of obesity, which are astronomical, both in the United States and now worldwide, with 30% of our children now being considered overweight. And of course, overwhelming use of tobacco, which continues to be a huge source of morbidity and mortality, not just for heart disease, but for cancer. This global disease burden is manifested in sort of 3 ways. Heart attacks or myocardial infarction, ischemic strokes, which can be not only fatal but disabling and quite devastating, and ultimately heart failure. Dementia, especially ischemic-mediated dementia, should be on this list as well. And as we've heard, last year at this conference, we can now detect aging brains, aging hearts, using proteomics. And so our ability to identify each of these different areas and treat them earlier is becoming more mainstream. The pathogenesis of heart disease or ischemic stroke is really well worked out. This cartoon is of the inside of a blood vessel. Here is our blood vessel with red blood cells and white blood cells. We talked about the immune system just a bit ago and receptors. For reasons that are never clear in an individual, the single cell lining of an artery we call the endothelium is damaged in some way. We know that tobacco causes an acute injury to our endothelium. An acute fatty meal, McDonald's for example, can damage our endothelium. There are numerous things that damage this tiny single layer on the inside of blood vessels. With that injury, there is a scar that forms. And for those cooks in the room, it's like a Teflon pan. If you scratch that pan with the wrong utensil, like my wife often does, all of a sudden food starts to stick in that little crack, and it makes us crazy. Well, in that little crack, LDL cholesterol, which is traveling in the bloodstream, can start to stick, and it migrates in the layer just below this endothelium. This LDL particle is an irritant. It's inflammatory. it generates heat, and as a result, the body tries to heal itself. We just learned about this healing process, this threat. It expresses molecules, adhesion molecules, which trap white blood cells traveling by, and these white blood cells, mostly macrophages, migrate underneath the endothelium, engulf these particles, and become foam cells. They're aggressive, they're inflammatory, they generate heat, and over time develop a plaque. There are lots of Nobel Prizes in cardiovascular disease still to be had. Injury of the endothelium, why LDL cholesterol migrates there, why our white blood cells migrate there, what is the acute injury, is it shear stress? We know that plaques form, and we talked about nature and its relationship to anatomy. The coronary arteries are like the Mississippi River with all its tributaries and sandbars, and we can predict where plaques will form based on flow. And I get the opportunity to do anatomy in real time as we travel through blood vessels, and where these injuries occur is what we see out in nature. But why the injury occurs, when it's going to occur, the tempo of that injury are all things we don't know well. The inflammatory response, how do we control that in some way? There are lots of trials about anti-inflammatories, and we'll talk about them in a minute. But it's also important to realize that this blood vessel also has muscle. We learned about fascia and connective tissue. There is fascia and connective tissue surrounding these arteries. They are supple or stiff, depending on the individual, and they change at different times. Ultimately, this plaque becomes a zit, a pimple, just like when we were kids. And there are two kinds of zits, right? There's the kind that you touched and then you got a scab and an unsightly blemish. And they're the ones that were deep. And plaques in the arteries are very similar. They're a collection of white blood cells, and ultimately, the cap that surrounds them rupture, and a blood clot forms on top of it. And this can be the fatal event. This is a thrombosis in a coronary artery. This is a slide of a cross-section of a coronary artery. This white area is the lumen in the center. This is a plaque with cholesterol engulfed by white blood cells that's expanding under pressure. Ultimately, it ruptures, exposes the blood elements to this pus, and a blood clot forms. This is what a myocardial infarction looks like. This is what an ischemic stroke looks like. Now, the tempo of this progression, when is it going to occur? Why is it occurring? Are all things totally eligible for a Nobel Prize. Some of the young people in here will figure that out for us. This process is a continuum. It starts with cardiovascular risk factors. This plaque starts to develop. We know that in 2-year-olds who pass from other reasons, we can find fatty streaks inside their aortas. In kids who returned from Korea during the Korean War, autopsy studies showed that this process was already occurring. Otzi, the Iceman, who died 5,000 years ago from a spear in his back, had coronary artery disease. It's ubiquitous. It's common. It starts when we're young. And we'll talk about some of those reasons in just a second. If these arteries get out of hand, they lead to myocardial ischemia or angina or heart attacks. That can lead to a heart attack and arrhythmia and death. If you survive, the heart can remodel and lead to heart failure and ultimately to death. The Inner Heart trial was a really interesting study done by Salam Youssef in Toronto. He looked at 150,000 people who died from their first heart attack all around the world. And he was able to teach us that there are about 9 things that will cause most of the attributable risk for that first event. These are people who had an event. It's already too late to some degree. Abnormal lipids lead that list with an attributable risk of about 50%. Smoking, 35%. Psychosocial factors. Last year we learned from Dana Matthews that where your zip code is, your social situation can lead to premature illness. This is well shown in the cardiovascular literature. So loneliness, lack of community, 32% attributable risk for the first event. Depression, abdominal obesity, we talked about that epidemic. Hypertension with an attributable risk of almost 20%. Not enough fruits and vegetables, and I would add to this, too much processed food, attributable risk of about 14%. Lack of physical activity, diabetes, and alcohol. These 9 features identify 90% of the attributable risk at the time of an event. Existential crisis. 4 to 19% of these events occur in people with no risk. So the person sitting in my office, my friend down the street who's healthy, they're at risk and I might not know it. I have an opportunity to help them if I only knew. Our current screening guidelines are antiquated, and they're based on the premise that risk factors are the way to go. We currently screen adults between 20 and 49 years of age between every 4 to 6 years, and during that time period we emphasize lifestyle choices and we try to estimate lifetime risk. But we may be missing the boat. Once you reach 40, we use standard risk factors. We measure cholesterol, HDL, triglycerides, non-HDL cholesterol. If you listen to Peter Attia these days, we measure Lp(a) and ApoB and lots of other things. And how they contribute we'll talk about in just a minute. And we try to set up a program to risk reduce the patient. After age 75, and I'm sorry for those of you in the group, these are antiquated, we give up on life expectancy and we focus on quality of life. And we can individualize our prevention strategies. I would argue that because of our health lifestyle, we should be as aggressive in people over age 75 than younger, but not based on the guidelines. We use a calculator, an ASCVD calculator, to estimate 10-year and lifetime risk. You can get this on your phone as an app. You plug in some information and it'll spit out a number. What's your likelihood of a major adverse cardiac event in the next 10 to 15 years? The problem is this test or this calculator both under and overestimates risk depending on where you live. If you're educated and live in a very highly developed neighborhood, this will overestimate your risk. If you live in a very poor neighborhood with nutritional deficiencies or a grocery store desert, it can grossly underestimate risk. But it does give us an idea and something to work with. We've refined these studies or these risk calculators. A current very useful calculator is the MESA calculator, which you can also get on your phone. And it includes other features, in particular where you live, your ethnicity. South Asian males, for example, are the highest risk on the planet. So that is included in this MESA database. And it also includes an anatomic marker of whether or not a patient or a person has developed atherosclerosis already. There are now, in 2025, an additional 15 or so high-risk groups where none of these calculators even matter. These people should be treated or in a prevention program even if they are quote-unquote healthy. This includes a family history of early heart disease. My father had a myocardial infarction at age 37. And in those days, he sat in the ICU smoking cigarettes for 2 weeks in a chair as treatment. Now, he was a Harvard-trained physician, was chief of medicine at Walter Reed back in the day, very smart guy. And I remember him smoking well into his 50s, and as I went to medical school, he says, I know what the risk is. I went to Harvard, showed me his Harvard ring, and said, leave me alone. So family history trumps all. High cholesterol related to families, which is my problem. I have familial hyperlipidemia. The metabolic syndrome, where people have a big central tummy and associated with diabetes, chronic kidney disease, a number of chronic inflammatory conditions, in particular psoriasis. In women, we have two new groups, premature menopause and preeclampsia. Those two groups put women at higher risk, and they should be treated as such. Certain ethnicities, we talked about South Asians. There are new lipid biomarkers which are incredibly important in risk stratification, in particular lipoprotein (a), which we've heard a lot about in the last 6 months based on some outstanding new drug trials. We'll talk about that in a minute. Markers of inflammation, C-reactive protein, and the presence of peripheral disease, ankle brachial index less than 0.9. There are lots of new novel risk factors. And of course, we're in Boulder, and no talk in Boulder would be incorrect without talking about weed. So weed increases risk. Microplastics, incredibly important these days. And we know from autopsy specimens, because we still do autopsies from time to time, that we can find microplastics in coronary arteries, and they are probably another source of endothelial damage. The lipoprotein A particle is really quite interesting, in the news a lot. It's a standard LDL particle that gets buried in these endothelial cells, but it has, I guess, what's called a kringle, a large protein complex on the outside of it that allows it to interrupt our body's own heparin, and so it predisposes us to thrombosis. And it is the strongest genetic marker or protein for cardiac risk. We have new drugs, 6 of them now, that will be able to lower Lp(a). We don't know yet whether that translates into better outcomes. We can't wait. We've been waiting for 3 years, and I've been in practice now 30. We've had drugs that lower Lp(a) in the past, not very strong ones. None of them have been helpful, so we're waiting with bated breath. My second absolute is that in 2025, in anyone in this room, we have the ability with about 99% accuracy to determine whether or not you have atherosclerosis already. Calcium scores, which are a CT-based technology for imaging the heart, allow us to detect a surrogate marker of atherosclerosis, calcium. And a CAC score comes in lots of different flavors. It can be 0, where we don't find any calcium, and the predicted risk of an event is about 1 in 1,000, though there is one. And the number can go up. The highest number I've ever seen in a human is 6,700. And that guy is 87 years old. We've known each other for 30 years, and nothing has ever happened. And 2 weeks ago, somebody close to me had a calcium score of 1 and ended up with a myocardial infarction and a stent. So these numbers just say, yes, you are in the game. This is an old slide from Rumberger, who was one of the early CAC score people, and he reminded me always that calcium in an artery is only 20% of the total plaque in the blood vessel. There is fibrotic plaque, there is lipid-rich plaque, which we won't see on a calcium score. So a score of 0 is great, and a score that's positive is helpful, but there's lots of stuff we don't see under the C. It has led to a revolution in what we call CT angiography. So these days, if you ask me, how do I detect heart disease in an individual with as much accuracy as I can, the answer is a CT angiogram, where we get not only the calcium, but we can start to see the soft plaque and the fibrotic plaque within arteries. This is a CT angiogram. What you see here is the aorta. This is the main coronary artery, and this is the widowmaker, in the widowmaker position with a soft plaque surrounding it. This conference is a lot about AI, and there are 2 AI companies that are revolutionizing this diagnostic procedure, Clearly and HeartFlow. What's done is a CT angiogram is performed anywhere, and using AI, they can examine all of the images and all of the length of the arteries and all of the wall and determine hard plaque from soft plaque from fibrotic plaque. They can give us percentages. They can give us the ability to track plaque remodeling over time. We don't know yet whether that based care versus standard of care is better, but that's coming with the confirmed trial. But it is a way with almost absolute certainty, anyone in this room, we could determine what their risk is going forward. Now, actually the presence of coronary artery disease or not. What it can't do yet is determine whether that plaque is going to hurt you or not. I love brain maps. So this is a brain map I put together a number of years ago, which just sort of looks at the state of my mind as it relates to heart disease when I'm sitting with you in a room. It includes lots of things. Up here is mental health, anxiety, depression, your insurance, your finances. Are you addict? Are you isolated? It includes your lipids, your age, your diabetes. Do you have Lp(a), ApoE? What's your current mind-body status? What's your nutrition? Do you eat lots of fat or sugar? Are you paleo or whatever? And all of this stuff we sort of have to integrate in a 20-minute visit. Oops, next, maybe. You want to advance that? I think I'm dead. Oh, there we go. Oh, here we go. So as I sit there with all this information, how much longer do I have before I have to change to a healthy lifestyle? So last night at dinner, I was chatting with one of our colleagues, and sort of glibly, he said, I don't believe in doctors. We should just all live healthy. And the answer is sure. I mean, if we all lived healthily and didn't smoke and exercise and were skinny, we were all born with an LDL around 30 and we did all the right things, we wouldn't have this conversation. We'd probably be hit by a tiger or hit by a bus. But we don't. We live an American life in America or a European life in Europe, and we enjoy our life. And so our risk factors are never perfect. And this is the other conundrum or existential crisis. We have the guy who says, yeah, less cholesterol, I do regular checkups, no nicotine, no alcohol, low sodium, moderate exercise, no sugar, and of course, the safe is going to hit him in the head. This is from my New Yorker colleague out there in the audience, Joshua. So prevention takes lots of forms. We know it works. Preventive strategies prevent disease and prevent events. There's no question about that in today's world. There are lifestyle modifications that we'd have to entertain: tobacco cessation, exercise, whole food plant-based diet, or the Mediterranean diet. That's how people ate in Crete in 1950. That's not the latest restaurant in New York City. We can fight stress and isolation. After a bypass operation, if you're a male and live alone, your mortality at 6 months is around 60% if we don't create community. We can address weight. Weight loss is important in risk reduction. And we can look at a lot of the other social determinants of health in an individual. Lots of pharmacologic agents. We have antiplatelet agents to stop that thrombus from forming. Aspirin, Plavix, which is a more advanced form of aspirin. We have drugs to improve endothelial health, ACE inhibitors, angiotensin receptor blockers. We have wonderful new drugs for weight loss, GLP-1, GLP-2 agonists, which can really, they're remarkable. And there's not a day that comes out that there's not another article about how beneficial it is for something, since it seems to address our addictive behaviors. And then there's lipid lowering. Lipid drugs are amazing these days. We've come a long way from the old days of cholestyramine. So when my dad first had his heart attack, he came home on cholestyramine. And I don't know if anybody's taken that drug, but my dad farted every day, nonstop, and loved it. He owned it, as my sisters would say. We've come a long way. We developed statin drugs, which come from nature. God created those in the backyard. He fermented white rice, and the Japanese botanist who discovered them died like 3 months ago at 92. And Merck developed that into lovastatin or Mevacor, which is still available, and now we have a whole host of statin drugs. They work in the liver by stopping the creation of LDL cholesterol. We have a whole host of new drugs, PCSK9 inhibitors. The PCSK9 receptor lives on the liver, and we have an LDL cholesterol receptor, and as LDL travels by, it attaches to the receptor, it's engulfed, and then we get rid of it in bile. Well, we know there are families who have a knockout. They don't make this PCSK9 inhibitor, and so they have a lot of these receptors. They clean their blood exquisitely well, and they drive their natural LDL cholesterols are around 30, and they don't get cardiovascular events. So we have two drugs available, Praluent Repatha, and we have an mRNA compound like a vaccine that can also stop creation of this PCSK9 inhibitor, which have led to outstanding results as far as LDL cholesterol. This is an amalgamation or a meta-analysis, if you will, of all the LDL cholesterol trials that we have available, and they're very clear and not really controversial. The lower the LDL, the less likely you're going to have an event. The cut point, based on standards today, is around 100, but you were born with an LDL around 30, and there are individuals who benefit from lowering LDL cholesterol lower and lower. In Europe, the current guidelines for high-risk individuals is 30 milligrams per deciliter. And so lowering LDL cholesterol, for me as a cardiologist, is a fundamental part of prevention. What's really exciting with PCSK9 inhibitors is we can get regression. So we can now start to reverse some of the heart disease. We knew that with statins, but regression was about 6%. And we participated in Boulder in some of those trials a long time ago using ultrasound. Nowadays, with PCSK9 inhibitors, we can get 27% regression at 24 months in the most aggressively treated patients. So this is really attractive if we can start really young. And this is going to revolutionize how we take care of patients. So what's my existential crisis? I've got great diagnostic tools. I have therapies that work. Well, who are the patients with risk factors who are going to go on to develop disease? Because not everybody with plaque in their blood vessel ends up with a problem. Who are the patients with disease who are going to go on to have clinical events? Who's that person with a calcium score of 2 who's going to have a heart attack next week? Who are the patients who've already had an event who are going to have another one? How do I know who that guy is, especially when I've done everything right? Are there patients who I haven't done enough for and not enough risk reduction? Or are there people I should do more for? And lastly, not on this list, is what should you do as the patient? What are you willing to do? Are you willing to become a vegan? Are you willing to take a statin? I mean, statin's the evil word, right? How many people hate statins? Just out of curiosity. Put your hands up. Who hates them? Look at that. Why? You know, we're not going to get into it. But we have reasons, right? The Wall Street Journal, the New Yorker tell us that statins are evil. But we know that may not be true. That led to dinner with Larry. In 2015, Larry invited me to dinner with Steve Williams, and we were having dinner, enjoying wine, talking about books, if I recall. And I was describing this existential crisis. I've got these patients, calcium scores of 0, who have events. And I've got another guy who's got a calcium score of 6,000. Nothing ever happens. Ah! And Larry said, I can help you. I think I have an idea. Proteomics was just starting then, for the most part. There had been a clinical trial, or not a clinical trial, a validation trial that Peter Gans had published in JAMA, which looked at the development and validation of a protein-based risk score for people with cardiovascular disease. They had taken the Heart and Soul trial out of UCSF. They had measured 5,000 proteins at that time and developed, on 3 proteins, I think is correct, a model for detecting events. And he told me, dude, I can tell you who's going to have an event in the next 4 years with a single sample of blood. And in my lifetime, we're going to do it peeing in the toilet. That's what he said. And so that led to, I was like, wow. And so somebody asked me, how have I been infected? My crisis had an approach. It was mind-boggling. And one of the greatest gifts Larry gave me is that he allowed me to participate in a clinical trial here in Boulder. He said, look, let me give you SomaScan. Let me give you the tool to tell your patients whether or not they're going to have an event, independent of their LDL cholesterol. Well, we didn't know that at the time. Let me give you a tool so you can know who's going to have a problem. So we launched in Boulder, and me as a general cardiologist, trained at the University of Colorado, the opportunity to do a clinical trial was amazing. And we did a real-world trial using SomaScan, and I think was the first prospective trial using the technology. We collected real-world input from patients about what this test would mean to them. We asked clinicians what they would do with their information. We actually measured their risk and compared it to traditional risk factors in that individual. We enrolled 200 patients at the time. And this started in 2017. The labs were done here in Boulder at the SomaLogic, at that time, campus. We measured 7 proteins at that time, and they represented growth and remodeling of arteries, inflammation, proteases. And for those of you in the proteomics world, a lot of these proteins don't just have names, and we don't know why or what they mean, but these were the ones that we used. And we looked at prediction of cardiovascular events over the next 5 years, and we followed those patients going forward. We defined risk. Low risk was under 9%. The highest risk was between 60 and 100%. And this led to a publication by our group in Circulation, looking at the results of these 200 patients here in Boulder. So let me tell you a little bit about the trial, and then I'll stop and answer questions. We had 244 patients ultimately enrolled. Our population was typical of cardiovascular studies. We had 76% males, 24% females. Underrepresented women, of course, still. God, men are so stupid. The mean age was around 66. We diagnosed coronary artery disease by imaging in about 50%. So these are people who had positive calcium scores or CT angiograms without clinical events. And 51% of our patients had had an event. They had been bypassed, they'd had a myocardial infarction, and they had received an angioplasty for a variety of different reasons. What we learned is that at the onset of the trial, 143 of these patients were already on what we considered guideline-directed therapy. They were on their aspirin, they were on their statin at that time. We didn't have PCSK9 inhibitors yet. They weren't all necessarily at goal, but they were at least on therapy. But 42% of the patients were not on guideline-directed therapy, despite having disease. And this is consistent with literature that's been published a year ago in JACC, where they looked at 600,000 Americans who had had heart disease, and only half of them were on any therapy at all. So we're not very good at getting people on drugs for prevention going forward. This is the risk profile of our population, and this in and of itself was really quite outstanding, or quite disturbing or concerning. So the majority of our patients, despite having diagnosis, were considered low risk, level 1 and 2. But there were a substantial number of patients who had event rates that went up to 100%, and this turned out to be true clinically. So this is the spread of risk over these patients, and there were patients in the higher levels. It turned out that this risk assessment was independent of what we thought as clinicians. So patients with the highest cholesterol levels often had the lowest risk. And in the highest risk groups, their LDL cholesterols were often normal. And this was, again, doctors aren't the smartest in the world, eye-opening. So when I sit with somebody in the room, another existential crisis. The things I think are going to predict risk in this individual may or may not be true. They may offer the only target we have, but it's not sufficient to know what's going to happen to any one given individual. The result of the SomaScan allowed us to reclassify patients. It also, when given to patients those results, it changed their life. So Larry, you have saved lives with SomaScan. People chose to eat better, they exercise better when they realized that I thought I was okay, or I thought my risk was low, I'm taking medicines, when the answer was no, that wasn't true. And it allowed me to give people risk-appropriate therapy. So in patients who were low risk, they didn't need extra statin, even though their LDL cholesterol wasn't optimal. They didn't need a PCSK9 inhibitor. Or the opposite. Yes, I know you don't think you're sick, but the answer is your risk is 60% of an event in 4 years. How does that feel? Would you like to do something different? And we've talked about all the different options we have on the therapy side. The study results identified about 45% of the patients who we advised there to be a change in therapy, either lifestyle or drugs. It called for initiation of guideline-directed therapies in those who weren't taking any medicine because they thought they were fine. The majority of the patients who were offered more intensive therapy were in the higher risk groups, of course, so the higher the risk based on their SomaLogic scan. We offered them more drugs, PCSK9 inhibitors, Zetia, et cetera. And these higher classifications would not have been associated with standard risk. Interestingly enough, despite all of the information, having had a heart attack or stroke or calcium score, having risk, having an elevated SomaScan result, 17 out of the 244 still chose not to do anything different, to live life fully without limitation. And I think that's an interesting group as we've gone forward. This is just an example of the results of our questionnaires that we asked patients. What would you do if you got your SomaScan result? And as expected, I'm at low risk, I'm not going to make any changes, I'm going to exercise more than 26%, eat better, all the standard things we hear. We should do them anyway, but this at least prompted them to make an active decision. So what did we learn? We learned that the use of a SomaScan results in conjunction with sort of standard assessment allowed us to address at least 30% of our patients in a more aggressive way, including starting guideline-directed therapy, intensification of therapy with risk-guided pharmacology. It advised patients to make different changes as it relates to their risk, including increasing exercise, weight reduction, and change in diet. And I would argue, and anecdotally, it saved lives. We've, since this trial, confirmed this in a prospective blinded fashion. So we took patients, actually these were all AI-derived patients, and presented them to real clinicians to see if they would make the same choices that we made here in Boulder. And this study that was published in Diabetology and Metabolic Syndromes this past year confirmed that clinicians would make similar decisions based on our registry study done here in Boulder. So, big questions. Existential crisis. Great, you have all this information. Will it change outcome? We don't know the answer to that yet formally. More to come. I will tell you anecdotally, just sort of 4 stories quickly, I'm going to run out of time, that we learned that high risk is high risk. I'll tell you about patient 42, 70-year-old, had had a bypass and angioplasty. His LDL is 107, twice what it should be in today's world. His calculated risk was about 29%, still pretty high risk, but his measured risk by SomaLogic was 65%. That was enough to scare him. He added Zetia, and now on a PCSK9 inhibitor. He actually went on to have an event in our 4-year period despite that, but was saved because of a defibrillator. His life was saved, and he's not had another event since. When I started in cardiology, we had the oculostenotic reflex. If we saw a blockage, we put a stent in it. Anybody who read Malcolm Gladwell's new book saw our practice highlighted because we did more angiograms here in Boulder than anybody. And we put stents in a lot of people. Not always the right answer in today's world. A 66-year-old who had a blockage in his LAD. LDL cholesterol was 60, ideal, but not based on current guidelines. The calculated risk for an event was about 15% over the next 10 years. His measured risk was even lower than that, 12%, and we had opportunity. LDL could go to 30. We could add PCSK9 inhibitors. He was asymptomatic and felt like this blockage was threatening him and went and had an angioplasty because he just had to have it removed, even though this is a systemic disease. He had a complication and died. Could we have done better for him? I would argue yes. Some people just don't think they have a problem. 60-year-old coronary artery disease, LDL is 127, that's average in America. Calculated risk was about 20%, measured risk by SomaScan, almost 60%. That was too much. All right, I'll take medicine. I will change my life. There are some people who think, wow, why are you walking on the planet? And they are. My friend with calcium score of 6,700. 61-year-old, had had a bypass, LDL cholesterol is 150, 5 times what they should be. Calculated risk based on their standard calculators, almost 50% that they're going to have an event. Measured risk by SomaScan, 11%. We could reassure them. We could continue with secondary prevention as we were going. So lots of opportunity using proteomics as the anchor. Recently published in Science and Translational Medicine, an article really led by Steve Williams, I got a chance to be part of it, has now used an advanced model of proteomics in patients. And in this study, we looked at, I think, almost 125,000 patients from a variety of different subsets, ERIC database. And with an enhanced model, we were equally good or better at predicting events. But the key to this article, and really what's revolutionized this, is it showed that we could measure improvement with proteomic results. So in this case, lifestyle modifications or GLP-1 agonists reduced risk, and we could measure that without having to wait for an event. Because the other existential crisis I have is, how do I know how good I am? Well, the only way I know is time. And I always tell people with, success is nothing happens over the course of the time we know each other. And so sometimes that's not good enough. So I'm sorry, we did everything we could before Elon cut our funding. Sad but true. We had a lot of work to do. And I want to put a plug in for Coles. Larry is the chairman of the board. We have an initiative trying to start here in Colorado of a new biobank that will include proteomics. I've been lucky enough to be a board member, and one of our initiatives early is to start to look at proteomics and cardiovascular risk in people who live in Colorado. We're going to be able to look at the impact of their dog, look at where their zip code is, lots of different things, but it's important to start to learn about, can we find people earlier? Because lifestyle modifications are the best. Dewey, I think you said it. We want to do this naturally. So eating well, doing everything right early would make a lot of sense. It's not the American way. And so this is a really important program that we're trying to launch here in Colorado. The SomaScan has gotten a lot better. We now look at 27 proteins. We can look at heart failure onset, dementia onset. And this is an integral part of my practice in taking care of my patients when they've done the best they can do, or they're not convinced that they're at particular risk. And it's really changed individuals who I've cared for over the time. So I always stop, I got 17 seconds, with a poem. The Laughing Heart. This is Boulder. We have beat poets here. This is Charles Bukowski. Your life is your life. Don't let it be clubbed into dank submission. Be on the watch. There are ways out. There is a light somewhere. It may not be much light, but it beats the darkness. Be on the watch. The gods will offer you chances. Know them, take them. You can't beat death, but you can beat death in life, sometimes. And the more often you learn to do it, the more light there will be. Your life is your life. Know it while you have it. You are marvelous. The gods wait to delight in you. Thank you very much.
Elbows by John Fox. The sacred quality of arms, particularly elbows, that make each of us working class, put us here for a purpose. Look at elbows and what they say. Elbow your way into a passive crowd to do what is needed. Give it your elbow grease. This is enough. Elbows, no one can possess them because they disappear when you move them. Into action by choice. And that choice is prayer in action. The deepest current of love. I apologize for what I'm about to say. The deepest current of love is not found in the heart. That is the certain spring, the natural ease, the flow from the mountaintop. The greatest current of love rushes forward in the choice to make a cradle of the body.
You know, the Gold Labs, right? Anatomy, basic science, poetry. I mean...
I only know that from going to a conference where somebody gave a talk about elbows and says, nobody writes a poem about the heart. So, we have questions? I need to look at the people who are the holders of the microphones.
With their elbow.
Please start if you have a microphone. Yeah. Yes, Sandeep.
Hey, that was great. And also, as a South Asian male, I think you've realized I need to befriend a cardiologist.
Absolutely.
So I have a sort of broader question. So the CDC publishes the top 5 causes of death. As you've pointed out, heart disease is number 1. In your utopia, what should the top 5 causes of death be?
Jealous lover. It's a great question, and I think that's a philosophic question. What should we die of? I think about another Dylan Thomas, rage, rage, rage into the light. I think a good death is, we don't know. I mean, I guess it's the normal autopsy. But that's a superb question. I don't think I have an answer for it. Yes.
Please, if you have a microphone, please go ahead.
Hi. So I'm wondering about all those proteins you kind of threw, or the groups that you kind of threw up there at the end. Do you have any favorites? I mean, from what you learned from the proteomics?
Well, so there are a lot of dilemmas as it relates to proteomics. None of the proteomic data suggests a target So, wow, your inflammatory markers are higher, that's where we should focus. Your this marker is, so we should do that. I think it's an incredible opportunity, and my guess, Larry, you know better than anybody, that there are people looking to understand these proteins, what they do, and are they potential targets. Before we had proteomics, we didn't have very many. We had troponin, which is a marker, or CPK-MB. These are markers of myocardial injury, and you can detect them in the blood in the months prior to an event, if you could draw them. The marker of the year is brain natriuretic peptide. It's a BNP, which is the body's own diuretic therapy. Insurance companies, if you didn't know it, when you go get insurance, are drawing a BNP as part of their cholesterol. And if your BNP is elevated, that is a marker of future events. So I have a few that I can name that we're using outside of proteomics regularly. But it's really exciting. I mean, these 27, some of them we know, some of them we don't know. They cross a whole range. And the problem is this atherosclerotic process is dynamic. It's changing all the time. I mean, the day before an event, how did you know you were going to have an event? And one of the trials we've tried to do, and we've actually started to collect samples, is we meet people in the cath lab who are having an event. If I had their blood from the day before, would I have known? Could I have known? And also, at the time of an event, if we have their proteomics, it should be 100%, right? The event rate at the time of acute MI should be 100% if this process is true. We don't know that yet. We don't have samples from an acute MI naturally. We do have samples that were drawn at the time of an iatrogenic MI, septal ablation, where we kill muscle cells, and it did show correlation, but in the natural state, we don't know that yet.
Can I try that again? Any surprises?
No, no surprises. Other than, wow, I just don't know. That's a big surprise.
Have cardiologists come to any agreement about what are the standard for social determinants of health?
No. There are lots of them. I mean, I think we don't know yet. I mean, I think zip code. I would say the answer is yes. So the current standard is zip code. So if you look at the newest version of the ASCVD calculator, the new pooled core includes zip code. So depending on where you live, that does have some, I guess, risk associated with social determinants of health as determined by your location, but not loneliness, not lack of community, those kinds of things. Yes.
Hi, very nice talk. I wonder whether what's the confidence level for some of the risk factors. And we understand that the lipid level or exercise are important, but with the stuff like eating a lot of fruit is good for you. And what's the evidence? Is it just nice correlation data? This is
right.
How confident? Yeah.
Right. So I will tell you every nutritional trial published to date is an observational trial. So the answer is there's always a lack of confidence because people self-report what they eat. So when people talk about whole food plant-based diet versus DASH for Mediterranean, there is always some lack of confidence based on the construction of the trial. There will not be a randomized trial, vegan versus whatever. I mean, that would be almost impossible to do. So yes, there's some lack of confidence with exercise, lifestyle modifications. I don't think there is much issue related to tobacco reduction. You can measure nicotine in the blood. So there are certain parts of them it's varied. There are at least, 30 or 40 contributors to a cardiovascular event. So it's a good question to ask. I think the only thing we have confidence is in lowering LDL cholesterol. And that's not perfect, by the way.
Can I add one thing to that?
Yeah.
And correct me if I'm wrong, because you're the expert here, and I'm just the moderator guy. But I think the Interheart trial is from like 21 years ago.
Yeah, Salam Youssef, yeah.
And in the time that's passed from then to now, although the exact study hasn't been reproduced, all of those factors have been studied in a lot of different trials, and they all end up being about the same. I can't tell you anything about quantifying the risk except to say there's consistency across trials across 2 decades that collection of factors that you talked about all contribute. And sometimes the study is of all of them together, like their collective influence, and sometimes it's individual. But what we know is that those factors are risk increasers consistently across studies?
Yeah, I don't think there's any question. I mean, I really don't think there's much question. Though they want to be. I mean, people, it's controversial, what do you call it? When people want to, conspiracy, you want to, it's not the LDL hypothesis or this, that, and the other. So I think there's lots of room for wiggle room. And we're getting smarter, that's for sure.
Thank you. It's very interesting. I'm interested in how you apply the proteomics practically, and what value you derive from them in that process now, as opposed to what may or may not be in future.
Right.
And of course, the big variable in everything is time.
Yes.
These things all take time. So can I just recap? So it sounded to me as if first you had applied the SomaScan techniques, and you said, lo and behold, my understanding of risk doesn't necessarily jive with what I'm seeing in the proteomics. Okay? Maybe I need to change my model. Let's take a look at this, test it. Okay? The second thing that caused, as you went through this, you said, my gosh, patients' understanding of risk, it's not really an understanding of risk, it's just the numbers in front of them. It said up here 55%, but in fact the proteomics says 15%. That's a big difference, or vice versa. But it caused the patients to pay attention, particularly if the risk factor was suddenly 53 as opposed to 20, right? And take action. So you said patients did react to that, right? We don't really know, and maybe I'm behind in terms of time, what the real outcome of this was in terms of real world outcomes for patients. Right. Did this actually deliver a better result in the end? We don't know that for sure at this point. Is that right?
That's absolutely correct. So, so going backwards, that is the what I would like to see in my life. So the outcomes trial.
Larry would like to see that too.
And we, Steve Williams as well. Who is going to do that trial? I wish it would be me.
Right.
But the answer is we need an outcomes trial to blind, much like the. I mean, my wife's an oncologist, and this is what is very similar to breast cancer and the foundation testing, where we have to show that if you have these certain situations, you have a better outcome. So that has to be
the last thing. So right, and that's critically important. I mean, that's either makes or breaks the game.
Right. However, that being said, sometimes the SomaScan isn't necessarily. It's a different way to present information to an individual such that they'll make the change.
Right.
We do know that if we can lower their LDL cholesterol, we will improve outcome.
Right.
So if the answer, so the SomaScan may or may not have made the decision, but if it made the decision in you, and that led to a lowering of LDL cholesterol from 150 to 30, there's no question that that will be a positive trial. Right. It may not be due directly. I mean, could I have done that just by lowering everybody's LDL cholesterol to 30? Sure. That could be. It's trying to select the individuals.
And to that point about the individuals, and the trick in the game is, are we, in your approach and what happened, able to differentiate one individual from another so that you could begin to individualize the treatment?
This is why I love medicine. And the answer is,
of course.
No.
Right.
It's about the individual. I mean, I always tell people, oh, your risk is 1 in 1,000. I know all 1,000 people.
Right.
Are you the one? And so.
But did using the proteomic approach allow you to do that at this stage?
Yes.
I think you're going to have to use the tent outside to continue this conversation, or I'm going to be fired.
Yes. Okay. I will say one last word, and that is, I use SomaScan in people who are the best them they can be. So when I use it, when somebody says, look, this is the best me I can be. I'm taking as much medicine as I want. I'm doing as much exercise as I can. This is my diet, whether you like it or not. This is the best me I can be. Is this enough? And so I use it in that person to say, yeah, this is enough, or no, this isn't really enough.
Thank you, Nelson.
Thank you.